Well, hello, everybody. Welcome to today's TikTok series. This is session 5, I believe. I'm losing count of 10. We're offering nursing contact hours after each of these 10 sessions. They are also being recorded and they are available on our Mountain Pacific website. So the next session, I believe it's the 26th. I will have to double check. I'm sorry, I apologize for that. There will be polling questions that we'll bring up during the webinar, as well as a link to the evaluation, and we'll place that evaluation link in chat during the webinar. I don't know whether you will be claiming nursing CEs today, so one of our first polling questions is I'm going to ask what your credentials are, so that can help me identify who needs a nursing contact hour certificate. So you'll also have the ability to unmute yourself, but please keep yourself muted while the presenters are speaking. And we're also going to hold some time at the end for question and answers. And I know Dr. Arzubi and Dr. Gomi are very good at calling out for people because they want this to be very interactive. So please feel free to post your questions, comments, anything in chat. And then if you do have a question, just unmute yourself. We also previously had some homework questions, but we've also asked people that if you do have other resources or tools or guides that you are using, we would love for you to share them with us. The more the merrier. And we are compiling some resources, and we would like to be able to recap what was shared during all of our TikTok sessions at the end of our series. So you can go ahead and put that first polling question up, Mary, while I do my introduction of our guest speakers. So Dr. Eric Arzubi co-founded Frontier Psychiatry in 2019 to introduce an accelerated, more aggressive response to Montana's growing mental health crisis. He served as chair of psychiatry at the Billings Clinic for 5 years, during which time he led the creation of Montana's first psychiatry residency program and Montana's first empath unit for emergency psychiatric care. Before moving to Montana in 2013, Dr. Arzubi spent 10 years at the Yale School of Medicine, where he earned his MD and completed postgraduate training in general psychiatry and child adolescent psychiatry. And Dr. Riza Gomi holds a BS in computer engineering from Rensselaer Polytechnic Institute, a MSc in biomedical engineering from Johns Hopkins University, and a MD from the University of Massachusetts. He completed a residency in psychiatry and a fellowship in movement disorders and behavioral neurology at the University of Washington. He currently practices neuropsychiatry with a focus on cognitive, memory, and movement disorders. He is also active in engineering and clinic research, focusing on using advanced technology such as voice recognition to track and monitor treatment of neuropsychiatric diseases such as depression, schizophrenia, Alzheimer's, and Parkinson's disease. So with that, I just want to open the floor to our very talented, very educated guest speakers.
Awesome, thank you, Alana. And I'm gonna go ahead and share my talk here. And update, what is TikTok 5? You're right. So today we're gonna talk a little bit about Delirium. We're gonna recap what we've done in the past, try to get everyone up to speed. We have in case you haven't been, you've missed some of the earlier lectures, just gonna touch on previous talks, and then we'll move on and spend some time talking about Delirium. Something I think probably near and dear to everyone's hearts here. I'm sure we've all had a lot of experience with, and something I spend a lot of time talking about and consulting about with patients. Same disclosures as previous. I work with Frontier Psychiatry in Montana, although we're finally getting started in Wyoming, thanks to some partners that we've met through the TikTok series, so that's great. And BrainCheck is a cognitive testing company online that I also work for. And so just a little 30,000 foot view of our series. So we're about halfway through now. All of these have a trauma-informed care focus, and we're trying to touch on topics that are most helpful for you all in the nursing home setting. And just as a recap, in the first talk, Dr. Arzubi talked about trauma-informed care in general terms, and especially adverse childhood experiences. And what we looked at was really some of the reason, some of the motivation for doing this series in the first place, which had to do with the revised Medicare CMS requirements. And so there's sort of this requirement to say, well, facilities got to ensure that residents have culturally competent, trauma-informed care available. And what does that mean? Of course, that's not a very specific definition, because it's really more about how to listen, how to look for different signs of trauma, and how it might actually be presenting to you all these years later, and helping to navigate that. And we'll talk specifically today about how trauma-informed care will help your approach to patients with delirium. We learned how adverse childhood experiences has a huge impact on all aspects of your adult life, not just during childhood, but not just your mood, which we're used to, things like PTSD, anxiety, but also your cardiac outcomes, risk factor for infections, use of alcohol and drugs in your education and occupation. And then on the right there is sort of a little map, just helps me remember that there are a variety of different types of adverse childhood experiences. So there's the ones that I think are a little easier to remember that fall under abuse and neglect. And then there's also household dysfunction. These all have the potential to cause these long-lasting, lifelong trauma and issues for people. And these are things that will manifest throughout life. We also then spent on the second talk of the series, just to recap, we talked about some of our work at the facility in Lewistown, Montana. It's the State Mental Health Nursing Care Center, and some of our partners there. We did an intervention where we started providing psychiatric care and remotely, and tracking how that went. So part of the trauma-informed care background was that we wanted to honor people's autonomy. And so in getting to know patients, we were reducing the number of psychotropics they were on per their preferences. We were trying to reduce doses, and then also spend more time with them so they could understand, get to know us more as human beings, so it didn't feel as distant. And so we also then in the next talk talked about loneliness in nursing homes and how big of an impact that has on the outcome for residents. Of course, we talked about it's hard to measure loneliness, but there are some surveys and some tools out there that we shared, and we can you can always refer back to the previous lectures to look at those resources. But we looked at how loneliness impacts in terms of impact on premature death, on risk of dementia, anxiety, and suicide, and then what tools there were to actually address these. In this bottom right, this graph was there to point out that loneliness, social connection, had larger impacts on people's health and outcomes than even things like smoking fewer than 15 cigarettes a day, smoking cessation, alcohol consumption, things like that, which is pretty amazing when you think about it. And then we talked about some ways, and part of this series, and what we wanted to be helpful is to think about what are things we can do, what are practical things we can be doing right now that you can get off after this talk and go speak to some residents, and what can you do right away. And so some of the isolation, some things that seem very simple to relieve isolation are actually very helpful. So these were just some of the things we talked about: name tags, encouraging family to do whatever they can to reach out in different ways. If they were used to visiting a lot in person and no longer can, still scheduling time and reaching out by video or with letters, bringing in the community, grabbing as many resources as possible. This is not meant to be putting more burden or strain on staff, but really trying to bring in whatever resources you can. The last talk, so talk number 4, we talked about dementia specifically, and that's really the area I focus most of my time on. And dementia is going through a transformation, so it's important to kind of revisit and think about the definition and what we mean when we say dementia. And so I spend every day with patients when I'm explaining. Part of what I enjoy doing is the education piece, and we explain that dementia is an umbrella term. It's just like telling somebody they have cancer, except nowadays, 30 years ago, 40 years, that's maybe all you would find out. Nowadays, you get a very specific diagnosis. So you say, oh, I have cancer, but what kind? I have, type A, stage this, this kind of cell. And we're moving that direction with dementia. So you have to remember, when you hear dementia, if that's all that's in someone's chart, we're moving away. So CMS and others are starting to require more specifics over time, and new treatments that are coming out are going to require more specifics. So we can't get away with saying someone has dementia, because we need to get an idea of what's actually causing the dementia. Is it Alzheimer's disease causing it, frontotemporal dementia, Lewy body dementia, etc.? Is it vascular dementia? So not part of the normal aging process. Overall, it's an umbrella term. Some of the key points we touched on regarding dementia, as a recap, it tends to come on slow. It doesn't have to. So sometimes we get these surprise cases that come on a little bit quicker, but most of the time it's coming on slow. Most of the time you can see this gradual reduction. So you see a mild cognitive impairment, MCI stage, precede the dementia stage. Alzheimer's is the most common, but not the only type. As I mentioned, vascular dementia, Lewy body dementia, there's others we're starting to recognize, all very common. You have to have 2 or more cognitive domains be impaired, or functional domains, I should say, and cognitive domains, to be considered with dementia. So if you're starting to get lost in places you were previously familiar with, and you're getting a lot of late payments, that's when you're starting to think about dementia. If someone's early on and they're just having trouble maybe in one area, not quite, but once they hit that 2 or more functions, then we call it dementia. We usually will put a little modifier on their early, middle, or late stage, or mild, moderate, severe stage for dementia. You know, in the real world, what's happening is, you know, primary care, geriatrics, neuropsychology, neurology. It's really the frontline providers are the ones putting out these diagnoses. And we're moving into an era where there's more information to make more accurate diagnoses. But for a lot of patients, so more than half of the 5 to 7 million people living in the US with dementia do not have a specific diagnosis. They're labeled as dementia or memory loss. And so we're moving towards trying to give them more of a specific definition. We touched on, just to remind people, this graph to show what normal cognitive aging looks like. And the variation on that y-axis is just a few points. So it's not the whole range. So although some of this looks like a big decline, it's not representing, this is normal movement. So if you look at this, for example, verbal ability, the purple squares, verbal memory, numeric ability, those are all things you can see from age 25 to 81, really should not change. In some cases, they get better with age. Now, when it comes to reasoning, spatial orientation, perceptual speed, those are things that may slowly decline, but only a little bit, and not enough to impair your functioning. That's the key. So you may be driving a little slower. You may be avoiding driving at night. You may need to write down more notes to remind yourself about bills or things like that. But you're still able to do those things. You're not getting in trouble. You're not getting in accidents. You're not missing your payments. That's the key there. So remember, there is some normal aging, and some people are very sensitive to that. Will point it out. Oh my God, I can't remember names like I used to. Well, that's a little bit is okay. Are you still able to get by and communicate effectively? Yes. Okay. We also talked about how now we look at the progression of neurodegeneration in these stages, and this is across years and even decades. And so now we recognize dementia underlying it is this gradual accumulation of pathology, whether that's Alzheimer's or Lewy bodies or something else. Something's building in the brain. Those proteins are being deposited. Brain cells are dying. And it's going on for likely years, maybe 10, 20, maybe even more years before you are ever diagnosed. So these are things that are going on for a long time. And this is what's fueling a lot of our current research with finding new treatments. Early detection and intervention. I threw this slide up just to point out that we are getting better. We have more tools at our disposal. Some of what I do, if I get involved with a case and it has not been specified, is I will work to find that specific diagnosis. So you can see on the right-hand side of that chart where there's dementia here, you can see classically, historically, that clinical function line, that's where we rely on. So once people are starting to get lost, miss their payments, leave the stove on, things like that, that's what we're historically using to diagnose dementia. But now we know that we can actually move backwards. We can do cognitive testing, which will catch people in that mild stage. We will use brain MRI structure, which will catch people also in that early stage. not so much in the pre-symptomatic, but maybe to some degree. I do have some patients where I've been able to see and predict the transition to dementia before they had symptoms using MRI just by chance. And then there's all these other tests, and it's not important for you to remember exactly, but just to be aware that there are tests out there that help us identify this more specific pathology. Like FDG PET is something I use every week, just because I see a lot of dementia patients. CSF amyloid beta testing and tau testing, that's the Alzheimer's proteins in your spinal fluid, so I'll do spinal taps to get that. These are much more definitive tests, so that it's very, very helpful. And then just wrapping up with the dementia piece, which is really core since it's such a large prevalence in our nursing home residents, is, why do I do what I do in terms of helping with the diagnosis and then the approach is, when you have a specific diagnosis, it really informs the care. We are on the verge of having more and more treatments available. So that's going to be not just helpful, but it's going to be required. These new treatments are going to require that people have specific pathology confirmed diagnosis. For example, the drugs that may be coming out in the next year or two will require amyloid confirmation, which means we're going to have to find a way to get people some of these spinal taps or some of the amyloid brain scans. So it's going to be important for us to be aware of, because we may say, hey, I want to advocate for my patient. I want them to have access to this new drug. And so we need to get more specific. It helps families and patients plan for the future. It makes such a difference, as we all know, when people have these conversations earlier in life, while the person that's suffering from this disease can participate in those decisions. It also lets me bring in the multidisciplinary team. There's no cases of dementia being cared for by one individual. I don't think it's possible. I don't think it's ever happened, and certainly doesn't go well if it's attempted. So I need to rely on my nursing staff, my social workers, all my care staff to help out. And then the research implications, as I already referred to, is there are quite a few studies. In fact, I'm actively involved in some clinical trials with new therapeutics, and this is something I think is key to helping people going forward. Keep an eye out. This is something that you can point out to the providers you work with. So if you see a medical chart and the provider is seeing the patient and it says memory loss, this is empowering you to say, hey, what's the memory loss? Do you think this is dementia? And if so, what kind of dementia? Is it on the left there, amnestic, aphasic, loss of language, dysexecutive, and inhibition issues, personality changes, visual spatial, are they bumping into things? Are they not able to see where things are in the room? Sensory motor, what kind of dementia? And then beyond that, what stage are they in? Is this subjective, meaning I can't actually see any problems? The patient thinks there are problems, but I can't measure it. Mild cognitive impairment. Oh, okay, I can measure it on my MoCA or my MMSC, that's showing it, but otherwise they're functioning okay. Or is it dementia? They're actually they need a lot of help with their day-to-day. And then what's the underlying pathology, do you think? Do you think it's Alzheimer's disease, Lewy body disease, frontotemporal dementia? So these are all things you should feel empowered to ask. And this really benefits everybody to be as specific as possible. And keep in mind, there's a lot of areas where we can intervene. Even with our older patients, where I'll convince people to use their hearing aids, because I'll show them, wow, this is really contributing to your memory loss. And that'll very often motivate them where others may not have been motivated before. TBIs, hypertension, alcohol, obesity, these are all ways we can, these are modifiable risk factors. So preventing falls, that's one of the big reasons, of course, for not just breaking your bones, but we don't want any more damage to the brain. And then look at this later life, smoking, depression, social, when you add all this up, we think that 40% of dementia is potentially modifiable or even preventable if we were addressing all these ahead of time. So quite a lot of areas we can intervene in. And then last slide on dementia piece, just to kind of drive home the point. These are all things, bits and pieces you can take into your facilities now, is treatment of modifiable risk factors that we just talked about. So picking one thing to work on at a time. Don't look at this list and think you got to do all of these things for every patient. If you're not doing these, then the patient's not getting good. That's not how this works. When we want to build new habits, it's always one thing at a time. You give that time, get it established, and then you can pick something else. But you can see these are all examples of where even just one of these things can have a big impact on somebody's awareness and their cognition. Let's throw up that first poll now as we're transitioning to delirium. And dementia and delirium are very closely related, but we're going to focus on how are they different and what is delirium as an entity. Is someone able to?
Yep, Mary, can you? Oh, thank you.
Oh, great. Thank you. Oops. There we go. How many times in the last? Right. Yeah. So it looks like zero. It was very interesting. So 0 to 3. So most people are saying 0 to 3, which is very helpful. Of those people that are saying 0 to 3, anybody willing to sort of jump on audio right now and share? Do you think that do you think there's a chance that there's been delirium that wasn't recognized, or do you feel like your answer is you're confident that you've not seen delirium in this last 3 months? So yeah, as you can see the results there. Any comments from the crowd? Who's brave enough to say something?
So I was going to ask something, Reza or Dr. Gould.
Oh, sure, please.
So I wanted to ask about, so a lot of times with patients with dementia, I think it's a lot harder for people to be more confident about diagnosing like hypoactive delirium. Do you have any tips in terms of kind of spotting it? Because I know, patient long-term outcomes are a lot worse too with untreated delirium. So any of your practical tips for identifying it?
I will, we will get into that. So we'll make sure I touch on that. And hypoactive delirium is a specific kind of variation of delirium. And this is actually Dr. Duong that's talking under my name. I think I shared my link. And the key with that is hypoactive delirium tends to be more dangerous. Hypoactive delirium, when people have, and hypo meaning less active. So sometimes you're thinking of delirium, we think of people running around and maybe being agitated or having behavior that's very visible. Hypoactive meaning less visible behavior. Those actually have worse outcomes, meaning they're more likely their mortality is higher, they're more likely to pass away in a shorter time. So that's a very good question. And let's make sure in those next few slides we talk on how to point that out. Anybody else have any comments about where they work? And, is it that you just tend to work someplace where the acuity maybe is less, or you don't think people are having as much delirium? Or do you think like, is it possible, oh, the person was sick or something happened and maybe it was delirium, it was, they went to the hospital, the emergency room, so you didn't get to really follow up? Any other comments? I wish I could see all of you. Each week we got to do this. We start out with a lot of awkward silence, and then people kind of get warmed up, and then we get going. So we could just skip the awkward silence part, but someone's got to jump in. You got to remember, I'm a psychiatrist by training, so I'm okay with awkward silence. That's pretty much all I do.
Okay, I'll share. If nobody's sharing, I'll share. Okay, I personally not so strong in differentiating the delirium. I think it's because we have too many behaviors. We have a few too many people. I think it's because of lack of stimulation, because they're so cognitively impaired, hearing impaired, reject care. I think they get ignored, or they put in their room a lot so that they don't bother the more cognitively intact residents. But I think I'm thinking of one person that is ambulatory, and I think his delirium would be, he gets very agitated over nothing. Like the other day, he got so frustrated, he threw his teeth dentures in the garbage. He broke his hearing aid, and you couldn't redirect him. And then if you tested for a urinary tract infection, he had an infection. That might be delirium. I don't know. The other is I started to get to know a resident, and I started to sit with her and blah, blah, blah. Anyway, she became engaged, started participating in bingo. And then all of a sudden, one day out of nowhere, she was like, get out quickly or they're gonna harm you too. And she became all delusional that people were trying to kill her. And she had an infection, but I tell you, she hasn't sprung back. I don't know if that's delirium.
Okay.
Did it sound like delirium?
Very, very good points. Yeah, these are all things we're gonna touch on. So I'm just making some notes. I'll make sure I do. But yeah, these are all things that on the upcoming slides. So thank you for sharing that. Any other comments before we jump in?
I guess I just, Dr. Gomi, with my previous history, before I started, well, I was in nursing school and I worked in an Alzheimer's unit actually. And I would notice that certain residents would have behaviors, and I don't, would it be more so that delirium is kind of brought on by triggers? Because we would notice that at certain, around certain holidays or a certain meal, or even certain staff that would come on.
Okay. Very good, very good. Okay, these are great questions. So I want to touch on these in the context with what we're going to be jumping into these next few slides, and I'll make sure we touch on this. So just a recap, you'll get some muscle memory for delirium, so you don't necessarily have to remember the exact definition and kind of like think through these criteria, but just to kind of get us all on the same page as a starting point, DSM-5 puts out their criteria. There's this confusion management assessment method, There are a couple different approaches, but the common features are that someone's attention, awareness, that kind of just superficial orientation is disturbed. So like they suddenly are not knowing where they are. You have to redirect them, like their attention's floating off. That's one common piece. It needs to be an acute or subacute sudden sort of change in their baseline. So, if someone has, let's say, schizophrenia throughout their lifetime, it can't be part of that. If it's been going on for 30 years, we're not going to call it delirium. But so it's often something quick that changes. You will be able to measure, and we'll go over how you would do this, but something different in their cognition. So you say, oh, spell world backwards, or remember these 3 words, things like that. That frontal part of their brain under delirium is kind of just gone. So they can't do the very basic cognitive tasks you ask them to do. So they're not somebody, and this is not again, it has to be a change from baseline. So if it's someone with dementia, somebody with a known behavioral disorder, a psychiatric disorder, we have to be a little more careful with that. They certainly still get delirium. We just have to be careful with how we call that out. And so on. So it's a lot of ruling things out, but those are sort of the inattention, disorganized thinking, the consciousness change, and this kind of acute changes. These are the common threads with delirium. Let's throw up that next polling question. Do you feel comfortable detecting and reporting delirium? Now that we just kind of went over a little bit initially what delirium is, let's go ahead and ask this question. Thank you. Everyone's voting. Appreciate it.
So can I ask a question? So
Of course.
It sounds to me like delirium is more cognitive, like they can't do something that they did before, rather than some of the things I was saying, no?
No, not necessarily. So we'll get into, so what Dr. Duong mentioned earlier in terms of hypoactive delirium, the more common is hyperactive delirium. So that what you're talking about, which is agitated behavior. And so you will get people that appear psychotic in a sense, and that's delirium. So people that are confused about where they are, paranoid, oh my God, are they out to get you too? Quick, go hide. That's a more agitated delirium, which we're more used to seeing. The key that I want to make sure we nail down today, though, is separating that from like what's their baseline and how is it delirium. So, and what we're going to talk about in terms of trauma-informed care is that, let's say I'm somebody who's lived a long life, now I'm developing dementia, and I get an infection, and so I've been, my memory's been poor. I'm living in long-term care, or I'm living in a skilled nursing. I need help physically, having a lot of issues. And now I got an infection. And so now I'm agitated. I'm paranoid. I don't know where I am. I'm getting really upset. That's going to be, absolutely, that would be delirium, but just being careful to know what's their baseline. And from the trauma angle, delirium looks different for everybody, because if I experienced childhood adverse experiences earlier in life, and let's say that experience was something that made me very, just in general across my lifetime, suspicious of others, well, then it's very likely my delirium or my psychosis later will have that content, because some people are paranoid, some people are just angry, some people are, doing it. There's a whole spectrum of what delirium in terms of the behavior looks like. But we have to, and this is something that helps us approach people, is just keeping in mind that, okay, where they come from probably has to do with that. So one example is, I have a Japanese lady in her 90s who was in an internment camp as a young girl. And every time she has baseline dementia, but she lives in assisted living, generally actually impressively independent, but has a lot of help. Now, every time she gets sick, she thinks she's back in the internment camp, very paranoid, thinks, I'm like a soldier that's coming to get, that's the characterization that her delirium will take. But I don't say, oh my God, let's, throw antipsychotics at her, she's going crazy. I say, oh, I bet she has an infection. And so we want to get to that comfort level where you'll say, this is a change in behavior. I can see why their childhood experiences are informing what it's looking like. And I know to look for delirium. So we're gonna kind of touch on this a few times. So the poll question is, so actually pretty strong yes. So do you feel comfortable taking? Good. So 71% of you say yes. That's awesome. And then we want to make sure that percentage goes up a little higher. So just to recap, let's see here. So delirium approaches. So I kind of want to go through all this to make sure everyone's comfortable here. So delirium is a medical emergency that should be communicated to the members of the team, right? So when we say delirium, the reason we say that is because delirium is considered a medical issue. So whether it's infection or pain or dehydration, we're going to kind of touch on those things. That's something urgently that needs to be fixed, because we know that a delirium is bad for the brain, but also it significantly increases mortality. And the biggest thing we don't want to happen, right, where we work, is we don't want people to have to go to the emergency room, leave, and go to the hospital. That causes a lot of issues. So if someone's older, has a baseline dementia, the key is to know when they change from that baseline. So not assuming that, oh, okay, this is just part of dementia, but you can have sort of brief episodes of delirium. So to the question of sudden agitation, paranoia, and seeing that it's infection, that's absolutely a type of delirium. Detecting agitation, behavior, that's kind of a clue to say, okay, what's causing this? You always want to look at like, what's the underlying cause? And it's most commonly some kind of infection, some kind of medical change. And that's what we want to look at. Now, it could be something a little bit brief. Like, let's say somebody's starting to get a little like they wake up, they didn't get good sleep. And this is somebody whose brain has already taken a lot of damage. So they're closer to that delirium threshold. And let me back up for a second and point out that every one of us on this call can be delirious in a matter of an hour, right? If I handed out the right drug to everyone right now, we'd all get delirious. Or if none of us drank water and we went walking in a desert, we get delirious. So keep in mind, everyone is on the delirium spectrum. I can get delirious, but the people we're taking care of in nursing homes, they're closer to that because of these other underlying issues. And so if somebody gets a bad night's sleep, is dehydrated, didn't drink much, and we didn't notice, yeah, they might get up, throw dentures in the trash, get upset, and start slipping. But what happens, and this is what I was alluding to earlier when I said, are you sure you haven't seen delirium in the last month? Because it can be, doesn't have to, there's no definition that it has to last for days, right? It can be brief. It can be 30 minutes, an hour, because a lot of times when we say, oh, they're hangry, we're just gonna, but then you give them water and that kind of stuff. That's kind of the borderline now. I mean, is a full-fledged delirium? Maybe not, but if you hydrate them, address their pain, give them their Tylenol, they get a good night's sleep, and their behaviors changed a lot. Well, we're used to doing that kind of automatically, right? As nursing staff, as frontline caregivers, but you're preventing, probably, if that person was already starting to shift, you're preventing, that's how you prevent worsening delirium and someone having to end up going to the hospital. And so when delirium is suspected, we advocate for assessing the resident at least once a shift. So using a brief assessment tool. So it can be as brief as saying, hey, Mr. Smith, tell me the days of the week backwards, or the months of the year backward, spell world backward, or hey, remember these 3 words. And then, as you're working in the room, come back and ask them what those 3 words were. Those are all sensitive measures. Delirium really does impair that frontal executive circuit. So they will not be able to do basics. And keep in mind, you want to pick something that's a change from their baseline. So if they have a more severe dementia, they can't do that to begin with, we got to think of something else. So you're gonna have to be more tuned into their attention and seeing if that's changed. Avoid use of physical restraints and bed alarms. These are things that sometimes for safety, absolutely can be necessary because of staff shortage, or, if there is a safety concern, it's emergent. This is not a black or white thing. But we also know that using physical restraints, bed alarms, basically things that keep someone immobile, those do increase the risk of delirium. So that's why we say that as much as possible. Now, if the second they're going to get out of bed and they're going to fall and break their hip, that's another story. But as much as possible, getting outside, seeing the environment, having day-night cycle standardized. So window curtains open, daylight during the day, things like that. These are all things that will help that delirium. Oh, go ahead.
Why do you say bed alarms? Why avoid? I mean, I know it's a restraint, but why would that affect delirium?
It's really what I think these are all proxies for is immobility. So these are all things that are keeping somebody not mobile. And so that's going to increase their risk because it contributes to them not knowing where they are, just the healthy aspects of moving around, but getting fresh air, orienting themselves, because when I'm moving around, I'm getting stimuli. So I'm talking to others, I'm seeing other things. I'm getting information that I can't get if I'm lying in bed. And then the last bullet is using good interpersonal communication. So and this is really just when you're speaking to somebody with delirium, talk to them normally, and try to get that information. Are they disoriented? Do they know where they are? And you can get right to the point. You don't have to kind of speak down to them. And I'm sure many of us, or all of us, are already on that page. But I think when you see someone with delirium, they may be functioning so poorly that it'll be tempting to, but really in this case, you got to kind of override that temptation. Like, oh, they're acting like a 2-year-old, so let me talk to them like a 2-year-old. Not something you need to do, and it'll be more helpful if you are speaking very clear and direct, just keeping them state oriented. Okay, well, a couple more poll questions. What is the most common cause of delirium? I kind of already alluded to this because you guys made me screw up my order of operations here because it got me so excited. But so common cause of, mean staff, which I know many of the people attending here fall into that bucket. And then infection, bad food, which, during COVID is probably inevitable. And then polypharmacy, so too many medications. What do people think? Man, I'm not tricking anyone with the A or C here. That's too bad. Thank you, everyone. Any comments while people are answering? A lot of people are jumping on infection, but then also polypharmacy. Does anyone want to tell me why they're picking one over the other? It seems like those are the two winning ones. Someone different who hasn't said anything yet?
I will say something. I chose polypharmacy simply because I think it happens a lot more frequently in nursing homes than infections do.
Okay, excellent. That's a good point. Any other comments?
I think infections are easier to find as opposed to polypharmacy.
Okay. Good point. Who else? Looks like we got a 2-to-1 for the infections. So if we're talking about statistics, statistically speaking, if I look at, 100 people with delirium in nursing homes, both are correct, but statistically infections will be found more often in people but to the point of it's easier to find. Polypharmacy is certainly going to contribute. And so these studies are not good at saying, well, that person who had an infection and had delirium may have also been on polypharmacy. So, but absolutely those are the two most common causes or underlying kind of predisposing factors that will give that fertile ground for delirium. So very good. Those are both very important. And even if many of us are not prescribers here, you can absolutely help advocate for reduction of polypharmacy, because it's brought to my attention. I deal with it with my patients, but it's a core part of treating delirium, and we'll talk some more about it here. So risk factors, right, include, so that dementia piece. If someone has underlying dementia, cognitive impairment, that means it's easier to break down that frontal circuit, so it's easier for them to get delirium. Polypharmacy, restraint use, that's why we brought up the kind of keeping them in bed, that is a risk factor. Medical illnesses, frailty, advanced age, and alcohol use. These are all risk factors for delirium. And so the infection will be kind of the clear cause, but these are all things that will actually not just can cause it, but can also just set the groundwork. So people doing all of these things may not have delirium, but then it takes very little to push them over that edge. So patients that have had to be physically restrained are 5 times more likely to have delirium. So always ask yourself, and these are ways we can kind of catch for ourselves is, wait, this person's needing to acting out and having to be restrained more than usual. It's a chicken or the egg thing. Okay, well, why? Maybe there's an infection brewing and they're actually acting out more because of it. So these can be both directions, right, to give us a clue. Delirium and dementia, very overlapping. That's why we wanted to talk on using more the frontal executive type of tests, like the spelling something backwards, because they have to both maintain their attention and also kind of think through things at a superficial level. And that's what gets screwed up with delirium. So they're not able to, their short-term memory, things like that will look impaired. But with delirium, it's that kind of complex attention piece that will be poor. 68% of new long-term care patients have dementia. And so that's a very high risk starting point for delirium. And so that combination of delirium and dementia increases the odds of walking dependence. So look at that 15.5 odds ratio if they can't walk on their own. Institutionalization, meaning being in a facility, so 5 times odds ratio, 5 times more likely. And then 1-year mortality. So they're already almost 2 times more likely to pass away in that first year when you see that delirium and dementia. And then, so delirium management, there we go. So let's talk into delirium management. And so one thing we're going to come back here when Dr. Duong mentioned earlier was a hypoactive delirium. One piece is we talked a lot about these examples that are easy to point to, which is the hyperactive delirium, people with agitation acting out. It's almost like that psychosis that we're seeing, that positive symptom, right? And hypoactive delirium, you can think of as sort of similar to negative symptom psychosis. So they're more inward, they're not saying as much. So it's easier to not intervene because it's harder to detect. But hypoactive are the ones that tend to die sooner, have more mortality. And a lot of people, you'll think of, you've been around on their deathbeds, they have hypoactive delirium at the end there. So that patient, you remember, who sort of was just turning inward, there was some confusion, maybe obvious, but they weren't necessarily, you know, agitated and fighting, but towards the end there, they became more confused. That's a hypoactive delirium. And sometimes that can just mean, unfortunately, that's marking the end, that they're suffering something that's terminal. But hypoactive delirium also comes up earlier with that dementia polypharmacy infection. And that's a really important one. So when you see someone, they're not moving around as much as they usually do, they don't know what the date is, who somebody is, they're forgetting those people that they're used to knowing, they can't spell something backwards. That's going to be a big trigger to want to figure out, wait a second, are they dehydrated? Should we do a urine screen? And so the big conclusion we come to is good nursing care is at the core of delirium prevention. So everyone on this call has the power to prevent delirium and also treat it. And so some of the most common causes we've touched on is, mobility, hydration, in being engaged. Those are not just healthy to do day to day, but those are preventing these bad outcomes. And someone getting delirium means they're much more likely to have to call 911, send them to the hospital. They may never leave again. They might much more likely to fall. So we're preventing delirium in a high risk population with these interventions. Sensory input. Remember when we talked on how important sensory input is for preventing dementia? So hearing loss, visual stimulation, same thing with delirium. That helps people stay oriented. So having an all about me board mentioned here. So knowing what date it is, having a reminder, some pictures of their family, those kinds of stimuli, very important. And if they have hearing aids, great, making sure they're using it, but musical therapy, they call it sometimes called reminiscence therapy, but things that they're familiar with, all things that help people prevent delirium. Encouraging use of dentures. A lot of our older folks kind of get tired of it or just don't bother to put them in. But what is that going to do? That's going to reduce the diversity of foods they can eat, the diversity of tastes, and make it less likely that they're going to eat enough. So we just kind of want to do that encouragement. Some of these seem like very small things, but have a huge impact. As much as possible, the more they get to know you, if you're a consistent staff, that helps. If somebody has underlying dementia, polypharmacy infection, if they're prone to delirium, every time there's a transition, a room change, a movement, it can be a trigger. So that's something to really help them prevent that. Pain is also another common trigger of delirium. And so whatever interventions can be, it might be a little massage, might be, some foam rolling, might be some just basic Tylenol, Advil, but that will go a long way. I see, and someone asked about untreated sleep apnea. It's a good question. That will set the stage. That'll be one of those things that bruise it. It's not so much an acute cause of delirium, because untreated sleep apnea tends to be a very chronic issue that your brain has been dealing with probably for months or years. And so it will increase the chances of vascular disease, heart attack. So, vascular dementia, Alzheimer's, it will kind of build up towards it. So it'll be a fertile ground for it. But if I saw somebody and I said, oh, you have delirium, I wouldn't necessarily say, if I treat the sleep apnea, that's like the immediate solution, but it is still absolutely going to help. Okay, great. Let's see what else. Any other questions that I miss? Okay, great. And then, okay, and then you asked about dizziness and people who only experience that after starting to show cognitive decline in there. Dizziness is a really interesting phenomenon. We see a lot of variations of dizziness. And so it's a good question, because I think people experience dizziness very differently. It's very important to nail down what they mean by dizziness. Is it a vertigo? Is the room spinning? Do they feel off balance? Do they feel lightheaded, like their blood pressure is low? So there's a lot of different experiences. And once you nail that down, it can help rule out certain things. So you want to do a cardiac workup or a neuro workup, or, you're dehydrated. But overall, people's cognition as it declines, that's a good point. They may experience that as sort of a dizziness, and depending on culture and background, they might use those words to describe it. And so it's important to think about that. Absolutely.
I did have a question in there, Dr. Gomi.
Yeah.
Maybe not a question, but more just a comment, and maybe you have input on it, just how COVID would affect, because we're seeing that the older population are more prone for COVID, and even younger population they're seeing as a long haul symptom is as a mental decline a little bit and forgetfulness.
Yeah. So that's a really good question. So I mentioned at last week or 2 weeks ago in the talk with dementia that we're seeing a big increase in the rate of death from dementia, even without being directly having COVID. And that's stemming from the isolation and the loneliness we talked about previously, but also all of the COVID is increasing the odds of delirium because you're more likely to be isolated. You're more likely to be getting less exercise. So you're more likely to get dehydrated. I mean, all of these risk factors are more likely. And you know, if you're lonely, if you're isolated, you know, you're more likely to get on more meds. So if polypharmacy is going to increase, more likely to fall. So COVID is absolutely, it's increasing the risk of all of these underlying issues and causing more delirium. And that delirium is leading to more higher mortality rates. So COVID is a much, much bigger issue than the virus itself making us sick, which we have to deal with. But it's the sort of collateral damage is huge, especially for our patients in long-term care facilities. So that's a really good question, but that's exactly how COVID is impacting them. So delirium, there we go. And then just one more slide about delirium management. Here we go. So, I know we're running out of time, so I'll make sure I get through this. So when somebody is delirious, or you think that they're slipping a little bit, whether they're showing agitation, outward behavior, or more hypoactive delirium, but you're detecting they're disoriented, their attention slipping, this is another time to get family or resources, volunteers, anyone you can more involved, because the more reorientation, more stimulation that person has for their brain, the faster they will recover from delirium. So oftentimes, and I think Dr. Seiss is on the call here, and he's a champ at hospital consultations. So he sees lots and lots of hospital delirium, and we call it delirium protocol. And what we'll do is we'll go in and we'll say, okay, let's open up the shades. Let's find all these stimuli to give to the person. Let's try to standardize their sleep-wake cycle, their hydration. And these are all ways, and in order to do that, it takes a team, right? No one expects you to sit there all day and say, oh, no, remember, it's Monday, not Tuesday. But with each interaction, you know, that's an opportunity, and then trying to get people to help. These are great opportunities for families if they're struggling to know, I don't know what to do for mom or dad or grandpa, grandma. These are ways to help. Decaffeinated tea, back rubs. So these are all ways to help them transition, get their sleep at night. A lot of times with delirium, we see people are kind of awake at night, you know, sleeping during the day. That's important to switch that as best we can without using sedatives. So avoiding, sometimes it's necessary with a lot of agitation to use antipsychotics. We'll use some low doses at times, but as much as possible, we try to avoid that because whether or not it's a cause, it can help with recovery in the acute severe setting, but more antipsychotic use is associated with worse delirium, of course. Patients should not be sent home. So if you're in a long-term care facility, your patient went to the hospital, they want to send them back, and you don't feel like you have the resources, you should feel confident, you know, to be able to ask, did the patient have delirium during the hospitalization? Oh, okay, what happened with that? Did they recover? How do we know? And asking those questions before they come back. Medication review by consultation pharmacist. So you can, even if you don't have direct access to a psychiatrist or a specialist or even the primary provider, you know, you can always ask the pharmacist too, where you get the medications from. Hey, so, you know, what do you think about this med list? You know, I'm a little worried because this person's been, you know, this year had a couple of episodes of delirium. That's a proven method that we've studied that shows that consultation with the pharmacist and then ideas to reduce medications will help delirium. Using a clock or a calendar, these were some odds ratios I found I threw in there, or telephone. You know, when those are absent from patient's room, they're 2 to 3 times more likely to have disruptive behavior and associated delirium. So then they're more likely to get antipsychotics. So even really simple things like that little free calendar from, you know, some organization, that can be helpful in encouraging patients. Hey, let's track the dates. Let's cross off the days together. Things like that. And so just to kind of recap in terms of the dangers of delirium, why we consider this a medical emergency, because underlying it may be an infection that untreated will lead to severe, you know, illness or death very quickly. But also you can see patients in these long-term care facilities with delirium, their 6-month mortality rate is 25%. So a huge rate of passing away, which is, of course, is something we have a lot of power to prevent. People in those facilities without delirium, 5.7%. So it's quite a bit bigger. I mean, that with delirium, that's more than people with, you know, kidney failure or getting dialysis 3 times a week. That's a higher mortality rate, just to put it in perspective. Patients whose delirium resolved by 2 weeks without recurrence can get back to their original level. And so that's why we get into a really reinforcing that it's super important to aggressively treat that delirium, not just with that rehydration or treating the UTI, but, you know, getting their sleep on schedule, all those things because the faster we get them back, the more likely they'll get back to their pre-hospital function. Okay, last question, and I'll be done bugging you guys. Does early life adverse experience and trauma impact what a person's delirium looks like? We kind of touched on this earlier. While you're doing that, I'm just going to double check and see if there's any other questions. And anyone else wants to jump in right now, please do. I just want to make sure. Great. Great. You guys fell into my trap. That's why I wanted you to say yes. Very gullible audience here. So really what I wanted to wrap up with saying is that, and I gave the example earlier with my Japanese patient who had the experience in the internment camp, but as we get to know our patients, as we're that consistent staff member, as you learn more about that patient, that also will help detect delirium, because you will sort of see, and not always, but more than maybe we necessarily think, I'm always surprised with the flavor of that delirium will be influenced by those early life experiences. And so whether that's more of an hypoactive fear, keeping in paranoia, whether that's an outward agitation, there are reasons for that. I mean, these are not going to be random. They're going to be informed by a whole constellation of factors, many of which we're not going to be able to, you know, factor in. But we'll find as we get to know people, get to know our residents and our patients, things will sort of become easier to detect. So this is another reason where it helps to kind of have that long-term care. This is why memory care nursing homes are actually really good places for people. It's not, I'm trying to help a lot of my patients when they move in understand that, you know, it's not a failure, it's not a bad thing. Life can be very enjoyable because you can build long-term relationships there. The tools and the support are there to really help you live a longer life, but also with a higher quality of life. And fingers crossed, when we've got vaccines going around and people getting back out post-COVID, there'll be a lot more to do, a lot more stimulation. So these can be places where there's a lot of reward and a lot of positive feelings associated with it. And this is one of those ways we can help people. But when we talk about trauma-informed care with delirium, that's really what I wanted the take home to be, was that always keep in mind, why is a person acting this way? Am I catching delirium? It's something to treat, but also the nature of it, because it's more likely to present the same way the next time it happens as well. And so it's good to learn that about that person. The last time they threw their dentures in the trash, they had a UTI. And oftentimes that's kind of our clue. Great. And that was the end of the talk. So any other comments? I'm happy to stay on. I think I got 1 or 2 private messages, so I'm going to follow up with people directly afterwards, just to make sure I touch on everybody's questions. But any comments from the audience? And then Alona's posted the survey. Please make sure to fill out your survey. Also make sure to follow up about if you want those credits, just to make sure we have everybody's information. And hopefully, you all feel, if anyone still has questions about delirium, I'm hanging out for a few minutes. I want to make sure that you feel empowered to have that conversation with the pharmacist, bring in the family for stimulation, detect a delirium, treat it, characterize it based on those early life experiences. So I want to make sure people are feeling more comfortable with that.
Well, Dr. Gomi, this is Sarah Medley, and I just wanted to thank you. I'm not clinical, but I know there are a couple of team members on who are not clinical either from Mount Pacific, but we all love learning, and you do just a great job. So thank you. And I see Dr. Arzubi, I believe, is on with his fancy headphones there.
Yeah.
So thank you for all you're doing for our team members.
Absolutely. Don't give Eric any credit, please.
I know it's all you, right?
No, absolutely. And for those of you, for anyone that's non-clinical, truly, I mean, these are all things that we will all deal with in life directly, even if we're not seeing a patient directly, but in our families, you will be in situations where you'll be talking to your friend and say, I think your mom has delirium, and you will save a life that way. I have many anecdotes where that's happened. So it is important just because this is universal. So I think it's going to be to everyone's benefit to recognize
Absolutely. This. And the other thought I had that I can visit with Alana is our pharmacists would have enjoyed this as well. So
yeah, absolutely. Yeah.
We've got 9 or 10 of them in our Helena building. So this would be good to review with them. So we'll share the slides.
Absolutely. And then one of the talks coming up is going to be a little more focused on the kind of polypharmacy and the management of dementia and in nursing homes. So that might be relevant as well.
Excellent. We'll get them invited. I'll make sure, Alana, you can take care of that for us. Okay.
Karen, I don't know if you're still on the call, Karen Duong, that you asked that question. I just want to make sure, did I answer or you can tell me later if I answered your question. I just want to make sure the hypoactive delirium question was answered. I'll follow up with her. She may have jumped off already. Any other questions? Everyone else feeling confident about delirium? They're going to go ask their patients to do the spell world backwards and, count the days backwards. Good. Glad to hear that. Now you guys, it'll feel repetitive and annoying, but it'll feel good when you catch that delirium, especially for people with baselines where it may be hard to detect, those people with dementia or other underlying issues that are just kind of hard to know if this is something that's different.
Thank you very much, Dr. Gomi and Dr. Arzubi.